Fentanyl, the most often used opioid for intraoperative analgesia. But why is it so popular? Well, there are many different reasons for this. One is cardiovascular. Fentanyl has minimal cardiovascular effects. Fentanyl also releases minimal plasma histamine, which reduces the extent of constipation. It is short in onset of action and duration of effect. It is easy and inexpensive to synthesize and is familiar to clinicians. There's less venodilation and abnormal blood pressure during and post the surgical procedure, and extubation occurs sooner. Finally, it has various modes of ingestion. What about the history of fentanyl? It started with Dr. Paul Janssen, who worked with the piperidine ring in morphine and meperidine and produced analgesia. He worked to produce a molecule that had fewer side effects and higher safety margins. He also created fentanyl as fat-soluble to induce quicker onsets through crossing the blood-brain barrier. In the early years of fentanyl, it was experimented with and combined with other drugs to create optimal effects. For example, Dr. Jorge de Castro combined fentanyl with a butyrophenol called droperidol to produce an analgesia called a neuroleptalgia. Combined with nitrous oxide, this produced neuroleptanesthesia. The combination of fentanyl with droperidol in a 1:50 ratio was the only way fentanyl could have been approved by the FDA. Eventually, neuroleptalgia became less popular because of unclear results and contraindications. Dr. De Castro also explored stress-free anesthesia, which had minimal side effects, few cardiovascular changes, and blocked stress-responding hormones. This could be achieved, for example, through high doses of fentanyl. Patients had to be ventilated 3 hours after surgery. New research into other fentanyls emerged. Wild animal immobilization and anti-terrorist agents appeared with the help of carfentanil. In the 1980s, fentanyl was used for epidural anesthesia. Its high lipid solubility appears to localize its effects better than morphine. Oral transmucosal fentanyl was first developed for sedation, analgesia, and anxiolysis. Later, it was used for breakthrough pain episodes in patients who were opioid tolerant. Turbogesic was very successful in managing chronic pain because it produced a steady-state blood level of fentanyl that lasted for 2 to 3 days with a single patch. It was less useful for acute pain because it took 14 to 18 hours to get a steady-state concentration, and it could produce severe respiratory depression in opioid-naive patients even at the lowest doses available at that time. In one experiment, carfentanil was used instead of a squeeze cage in reducing anxiety. This significantly reduced emotional trauma for monkeys and inspired Dr. Stanley to think of a lollipop to reduce anxiety pre-surgery for children. Oral transmucosal fentanyl citrate (OTFC) allowed patients or clinicians to titrate the fentanyl non-invasively, simply, and easily. It could be easily removed. Orlit was the fastest opioid product available at the time, resulting in effective analgesia in 10 to 15 minutes. The patient did not need to consume the entire unit if they just rubbed the units on their buccal mucosa. Thus, the patients were able to titrate just the right amount of fentanyl for the analgesia they required at the moment the OTFC unit was used. Actic was for opioid-tolerant patients having BTP, breakthrough pain. It looks more medicinal and less like a candy lollipop. It was intended for out-of-hospital use, so there were more regulations to prevent overdose. What about addiction? Speaking of overdose. In the 1980s, fentanyl became sold as China White, China Girl, or Persia White. It's often combined with heroin, and even patches are sometimes consumed, the transdermal patches. It's often made in the US, Mexico, and China. The reason why it goes around is because it's cheaper and easier to make than heroin, and it's also more potent. Overdoses increased by 72% from 2014 to 2015. Because of addiction problems pervading users of fentanyl, many critics have argued against the use of opioids as painkillers. However, treating pain has been proven to help medical outcome and patient quality of life. Here are some proposed advantages and disadvantages of use based on the current literature. Opioids are effective, have low organ toxicity, and addiction can be minimized if monitored carefully. Disadvantages include that it is not appropriate for all types of pain. They can also have a number of side effects. What is being done to address the problem of addiction? One potential solution is to optimize opioid treatment to separate the pain management pathway from the reward pathway. This is difficult because pathways are intricate and often intertwined. Another potential solution is through opioid receptor complexes. Our current view of the receptor is as dynamic instead of an on-off switch. Complexes depend on available proteins for interacting with the receptor, the local environment, and the ligand occupying the receptor. Another solution is through exploring new opioid receptors. They can be constitutively active and activate G proteins in the absence of agonist ligands if the mice lack beta-arrestin. This occurs without being desensitized. Another solution could be mu splice variants. Different splicing of these mu receptors could result in different sequences at the N and C terminals, which results in different distributions, trafficking, and desensitization properties. Certain uncertainties are associated with this, such as whether drugs can be developed that have preference for a single splice variant and a single one only. Scientists can also explore other systems in combination with the opioid system. For example, the cannabinoid CB1 receptor is useful only for opioid reward, and the substance P receptor NK1 is useful for opioid reward and opioid withdrawal, hyperalgesia. A possible tactic would be to use antagonists for these systems. However, the antagonist for CB1 induces depression and suicidal thoughts, while the antagonist for NK1 does not even exist. Another example is the addition of a beta-2 antagonist to a chronic opioid regimen in humans, which might improve the long-term analgesic efficacy. Again, scientists can explore novel pharmacological targets for analgesia besides opioids, such as ion channels, other G protein coupled receptors, delta receptors, cholinergic systems, and even other molecular targets, such as the nerve growth factor. Now let's take a look at some of the effects of each delivery system. The UV system has the most rapid onset of action. The transdermal patch is for non-cancer and cancer pain, opioid-tolerant patients, and patients with severe gastrointestinal issues. It works best with fentanyl's lipophilicity and low molecular weight. It also has a high bioavailability. The patch has two forms and the matrix system is superior. This is because it decreases accidental overdose and drug leakage. It is also smaller and thinner. Iontophoresis, another method, also has its own advantages. While the transdermal matrix patch has a slow half-life, concentrations of fentanyl decrease quickly after iontophoresis. This is also easier than IV and good for people with nausea, vomiting, and dysphagia who struggle with taking fentanyl transmucosally. Lozenge sticks allow for direct absorption through the oral mucosa and a rapid acting point. Oral transmucosal tablets increase the bioavailability of fentanyl through a pH gradient, and the film is rapid, used for breakthrough pain, and most importantly in the context of abuse, which cannot be abused through crushing or inhaling. Now let's take a look at the mechanism of action. The G-alpha and G-beta gamma subunits dissociate from each other to perform their respective activities. The G-alpha inhibitory subunit couples with the adenylate cyclase to inhibit intracellular accumulation of CAMP. The GABA-beta subunits couple with ion channels such as the inwardly rectified potassium channels and the calcium channels to inhibit neuronal activity and may also modulate adenylate cyclase. For instance, if it was reported that the mu receptors result in G protein dependent inhibition of the alpha inhibitory and beta with the calcium channel. Not inhibitory, the subunit. The regulation of the receptor. How does this work? In desensitization, the receptor can be phosphorylated by GPCR kinases or other second messenger regulated kinases. It facilitates beta-arrestin binding, and it further couples to G proteins, and that's damaged. However, new knowledge leads us to believe that phosphorylated arrestin-bound GPCR complexes may not be simply inactive, but that it mentions alternate signal transduction cascades, including MAPK. Here I've provided a list of other examples of MAPK that the receptor is involved in, the mu receptor. such as ERK1 and 2 and J and K. Now let's look at what biased agonism is and how that relates to um, fentanyl. It is otherwise known as functional selectivity or collateral efficacy, which is the difference of different ligands in GPCR signaling. Efficacies and potencies are not conserved among diverse signaling cascades. What about the properties of fentanyl? It has enhanced phosphorylation of the receptor, but only partial agonist for the G protein coupling, which is strange. And it also has because of its properties as an agonist and G protein coupling and as robust phosphorylation, it has substantial desensitization of the receptor. It is also efficacious at interacting with CAMP and with respect to stimulating GTPase binding and internalization. But internalization may not be enough. What about carfentanil? Carfentanil binds to the mu receptor 1 and as an analgesic. It has some commonalities with fentanyl. Mu receptor 2 is associated with unwanted side effects. Carfentanil is a full agonist, but when it can be a partial agonist as well if you delete the positively charged nitrogen. It serves as an elephant tranquilizer, and it was used in the Russian hostage crisis. And I would like to say a special thank you to Dr. Evans for his research. Thank you very much.